sorry, no, it's fine. So we need to get the moderator and panelists for the next session could come up ASAP. That'd be fantastic because this is a really important panel. And how do you Welcome. I'll introduce you all. Okay. No, just sit anyway. Yeah. Okay, we're going to press straight on, and we're going to talk about the role of industry. I'm just introducing this session, so I'm going to be brief. Okay, the next slide. Okay, so how can industry help to develop the stuff, space, staff, and systems necessary for resilient health systems, including surgery? So that's the panel. We've all seen this before, and one way of thinking about this is how can industry really empower the communities, the community health workers? How can industry empower the primary health center level, empower the first level hospital, which is so critical for our bellwether procedures, and right across into tertiary care? But critically, another way is how can industry help to join those components? And so to promote a really interdependent network. And I think that's really, really crucial. And I guess how can industry really help to address some of these delays that we've heard about earlier? So this is another way of focusing our discussions. As I said, the staff, the actual individuals, and let's remember that industry potentially has a role in all of those staff. You know, not just the surgical providers, the anesthetic providers, but the lab technicians, the nurses, everyone involved, et cetera, et cetera. I'm going to press on. Now, in Bellagio, we had some thoughts on industry. And the first thought, industry has a critical role, it's profound, isn't it? It's a really profound statement. But of course, Bellagio is a wonderful place. It's a really good place to go and be. But we actually did do some work there. And we came up with this profound statement. And I think perhaps it reflects, because we haven't really been able to unpack it that much, that actually, as a commission, hands up, I think we've possibly thought less about this than we should have. Okay, I own up to that. I think we thought less about it, and I think therefore this discussion is really critical, and particularly as we think about implementation, the role of industry is so vital. And I think one of the things that we did come up with, which I think was profound, was engaging industry locally. This isn't this isn't just about international large organizations, but how to empower industry at a local level. And to think beyond the devices. So to really help us with that, we've got, I keep pressing the wrong button, George Dyer. George, come take your seat, and I'll be handing over to you in a moment. George is Assistant Professor of Orthopedic Surgery. When I first came to Harvard 2 years ago, I was totally bewildered by all the surgical initiatives, and George was one of the individuals I met at supper on the last evening, and it was tremendous to chat with you there, George. So George has a key role, particularly in relation to partners in health work since the earthquake of 2010. Then we have Stephen Ruddy, and Stephen, founding chief executive, a social enterprise supporting global surgery. Do you know, we really could do with you coming and setting up a social enterprise in southeast London, Denmark Hill, just by the hospital, like we could really do with that in our global surgery program. As an inventor on 10 US and international patents, lots of experience over many years. I think that's really good about many of our panelists. They've got a lot of experience to bring to the table, so welcome. Asha, we've met over Skype or a conversation. I enjoyed that a few months ago. Trained as a computer engineer at the University of Louisville, as you can see. Very much been working with GE for many years, but interestingly in the last 4 years, particularly focusing on the corporate citizenship, which I think is a really interesting area, and now leading on the GE Foundation program, Director of Global Health Program there. We've got Timothy Prestero. Timothy is former founder and CEO of Design That Matters, a non-profit that works with social entrepreneurs. And this is really important. This what's really relevant in the local context that I was referring to earlier. So welcome, Timothy. And then Amber Gaumnitz. And Amber's, again, got a lot of experience with partners in health and brings that experience in really setting up and building capacity in the low-income setting. So I think we're going to have a really interesting panel discussion. Over to you, George.
Well, thanks very much. It really is a great honor to be here at this event. So I not only look like an orthopedic surgeon, as Paul would say, but I actually am an orthopedic surgeon. But my interest has broadened beyond just broken bones, and I'm honored to have a part of this day. So Erica Frankel, who I was sitting next to during the morning, who came here with Steve, said, "This is great. It's like a commencement. You know, it's like the big day of global surgery." And I thought about that, and I particularly like that analogy because the word commencement emphasizes the fact that a graduation is not an ending but a beginning. And this really is a beginning, I hope, of some new, exciting, and effective work in this field. The role of industry is especially important because it is, to be frank about it, an area of danger, an area of real risk. It's a place where poorly implemented, bad things can happen, and well implemented can create all sorts of opportunities. And so this is a great moment here. I'd like, if you never read this article, I would suggest that you look at something written by David Welling in 2010 called The 7 Sins of Humanitarian Medicine. Raise your hand. Maybe David Welling is here, for all I know. No? Anybody read that, familiar with that? It's perfect, good. So it is, I think that's themes from that have woven their way through our discussion today, and I think we'll find ways to alight on most of them with the panel. I'd like to start actually with with Amber. So most of us who have worked in the low resource world trying to organize surgical missions are familiar with the junk for Jesus phenomenon, right? So you go into some warehouse where there is just an unbelievable heap of stuff that well-meaning, well-wishing people have packed into boxes and sent to the low-resource world because they think it'll help. And it's really a remarkable obstacle, I think, actually. And Amber's got a great deal of experience sorting through that, trying to improve that, and I'd love to hear your thoughts about that phenomenon.
So I've seen those rooms that are full of equipment that we can't use, that is just taking up space, particularly in countries where there aren't plans for waste management, which is very difficult in of itself. But my answer to that is that we solve that problem upstream. We don't take that type of equipment. We figure out how to say no and say it with kindness. But there is a lot of equipment that is just not appropriate for the setting, and that we need to really do our due diligence to know what equipment is appropriate for the setting, and that us as implementers should make a decision not to allow that equipment into certain countries. Rwanda is actually really good about it, and they have already said sort of definitively they're not going to take refurbished equipment, equipment that's 10 years old. They make real protocols about what they will accept, which really does help keep that sort of equipment out of the equation. So that is going to continue to be an issue unless we in this country or in the West or take that decision to not accept that type of equipment.
A related issue, which I think actually is probably worth highlighting at this point, is that to some extent, by participating in the low-resource world as surgical providers, we are part of the problem because we displace our hosts as providers, right? We compete with our hosts and displace our hosts. And that's something that I'm very aware of as a surgeon. The same thing happens with equipment, though. So when equipment is donated that might or might not work, it displaces purpose-built and purpose-designed supply, which was made for that purpose. And I'd love it if Steve could comment on that as somebody whose chief competitor is the donated broken machine.
Yes, I compete with junk. It's very embarrassing. But I think of donations as being the sign of a weak market, actually. And industries invest in their markets before they profit from their markets. And it's time for the medical device industry to invest in global surgery. And we saw some really dismal figures in the Commission report. 55% of hospitals without an anesthesia machine, 70% of operating rooms without a simple pulse oximeter. And with respect to donations, some countries obtaining up to 80% of their medical equipment via donations. And of that, 40% fails almost immediately in the field. It's either junk when it arrives, or more likely, it arrives, it works for a while, and then it becomes junk because there's nobody to repair it, even if there's a really small issue that comes up with it. And we just simply cannot allow the operating room to physically fail and still hope to meet any of the goals that the Commission has set out. And we have technical solutions for all the problems in the operating room. There is no major R&D research needed to come up with solutions for the key technical issues of power, lack of oxygen, lack of sterilization. I think what we're lacking in the industry is we need to reimagine the business models that we use here that simply don't translate well to low resource areas. Medical technology has its own version of a last mile problem. And with respect to our equipment, it comes in the form of poor in-service training when equipment shows up in an operating room, and just staggeringly poor service of that equipment over its entire life cycle. Imagine receiving a piece of life-sustaining equipment in your operating room, with nobody to set it up, nobody to train you, and nobody to call for service. And that is simply unacceptable here. It should be unacceptable anywhere else. But this last mile problem is also, I think, a magnificent opportunity for industry to invest in local industries in low-income countries. And for my organization, which has an anesthesia machine, we invest heavily in really three things in the countries we go to. Our distributors are typically undercapitalized and they're weak because there is not much of a market, so we need to support them. And distributors are important for really supporting the customers at the hospitals. We have an amazing absence of biomedical engineers. And this is a crisis throughout most low-income countries. We find engineers that we can train, and we actually help some of them set up their own businesses so they can develop long-term relationships with hospitals and relationships with other manufacturers and create a self-sustaining business for engineers. And then finally, with respect to training, we try to partner with universities and also individual moonlighting anesthesiologists because this peer-to-peer training is really what is so critical and what is so effective for us. So the Commission highlights the shortage of SAOs, rightfully. But there are other professions that need to scale up equally dramatically for us to really support surgery. And I think that industry's greatest contribution can be that investment into these local businesses to create a service and training economy, which in turn could actually grow and seed something much more vibrant, perhaps even getting to the point of designing and producing equipment in country. And I think this is a place for us to start.
Thank you very much. Your emphasis in that answer on training biomedical engineers leads me to a great question for Asha, whose company has taken that on. Can you tell us a little bit more about that?
Sure, absolutely. First of all, thank you for this opportunity. It's grateful to be here and represent the private sector and on this panel as well as at this conference. So before I get to the biomedical technician program that we have, just a quick backdrop on how we even embarked on that journey. When GE Foundation first started this program 12 years ago, developing health globally, we really went in with equipment donation because that's what we knew best. Quickly realized that isn't really solving the problem in this in the global health space, and it's really focused on capacity building and health system strengthening. what we realized with equipment donation is that after about a year of donating the equipment and giving that sustainability is a key component of all of our programs, you really didn't have the local skills to what, Stephen, you were mentioning, to be able to fix these problems. So with our mindset of providing simple interventions that are localized, it was really bringing partners on the ground in partnership with Duke and Engineering World Health, and working with ministries of health to pull together a curriculum and a hands-on training of what's called a biomedical technician program. So we started off in Rwanda with this program to design the curriculum that can be localized and partner with local universities and vocational training facilities, and also provide hands-on training to them. And since then, the program has scaled to 5 additional countries, and it's a huge need when you look at biomedical technicians and what they're able to provide, and some of the impacts that we made in this particular space shows that equipment donation alone is not going to fix the problems. It's truly on the capacity building side of things. And since then, BMET was really the start of our program in looking at the continuum of care and focusing on capacity building and looking at some of the other programs that could really build the ecosystem for this continuum of care.
Great, thank you. And Tim, I'd like to ask you, what do you think are some of the other barriers to effective engagement like that?
Yeah, I think we've covered a lot of ground. I think that I'll warn you, we've been called design the metaphors. So stories are a great way to tell some of the problems. I think one, in terms of equipment in global health, we were in a hospital in Nepal doing some background research. I asked a biomedical engineer to show me his favorite piece of equipment in the hospital. He thought about it, he's like, oh, I know. And he took me down to see the MRI. And it's like, well, okay, great. That's big and expensive and cool. I see why it's your favorite. He's like, no, it's not because of this. He took me around to the back of the machine and opened up a panel, and there's a voltage regulator built into this $500,000 device, which he thought was extraordinary. That's a $5 component, and yet that was sufficient to make it his favorite device. We've talked about how 99% of medical donations fail very quickly, and actually electrical failure is one of the main reasons. So that was story number one. Story number two was the first time, after doing a lot of field research overseas, visiting a surgical theater here in the United States after a procedure, and it kind of looked like McDonald's after a birthday party. There were wrappers and garbage, the trash cans overflowing. Basically, after every piece of equipment or consumable was used, it was all thrown in the trash. And that was normal. And I thought, oh, you threw that scalpel away by accident. Like, no. So, wow, that's all going in the trash. When we think about design for context, I think one of the challenges in global health is that there's this idea of, well, let's make things more affordable. One of the challenges that I want to point out with those two stories is that actually cheap has a floor. You can only make things so cheap. It's sort of like when you're hot, you can only take off so many clothes. So cheap has a floor, but better has no ceiling. So if we think about the thing that made that MRI so attractive wasn't that it was awesome. It was awesome. It was this cheap addition that made it better. So that's one. The other, when we think about how might we assist those who practice surgery in this context, you have to imagine yourself as a high school math teacher. And is your goal to get the kids in the front row to become astronauts? In other words, to enable sort of the most capable students? Or is your goal to keep the students in the back row out of jail? Or are you going to sort of aim in the middle and not really serve any student particularly well? And I think when we look at medical equipment design, many of the equipment that's provided in American hospitals is really intended to make the most capable surgeons to achieve sort of their unique potential, which is a very different goal from making it easy for the least capable surgeons in terms of resources and training to sort of keep them out of trouble, or to make it hard for them to use the equipment incorrectly. And then if we think about the goals, I think the biggest obstacle for industry is that they respond to demand. What is the demand? When we've seen RFPs coming out of low and middle income countries for equipping hospitals, they're often written as though they were equipping a hospital here in Boston. So when the RFPs are sort of aspirational in nature, of course you're going to get equipment that's inappropriate for the context. So again, if we think about the procedures that are recommended, the international requirements that are applied to devices, and if we think about sort of the demand, what does that tell industry? It says, well, keep doing what you're doing. You're doing great. So maybe there's room there. The second is the focus on outcomes. And this is sort of, your parents give you a shovel for Christmas and they don't know why you're bummed. It's not the gift you want to give, it's the gift they want to receive. And so I think that one of the biggest challenges, as we've talked about, is this difference between the cost to purchase something, the junk for Jesus. Like, let's get it over there, cut the ribbon, feel great, and then let's get the hell out, because we know they're never going to use it. So is it about delivery, or is it about outcomes? And if the focus is on outcome, then intent is insufficient. And as you were saying, we have to think about this entire system.
Thank you. Yeah, that image of McDonald's after a birthday party and all the garbage. So I'm going from here over across the street to the Brigham to do an operation. So right about now, they're setting up my room, my OR, and I guarantee you that there will be 3 full trash barrels before I walk in the room, right? So the birthday party hasn't even happened yet, right? And so the amount of trash that we have is unbelievable. And certainly the exporting that mentality and that habit around the world is probably not a great idea, because it's hard enough to manage trash here. It's even harder to manage it elsewhere. We have plenty of time for questions, and I want to open it up to the audience because I think we can have a really robust discussion, so please.
Hi, my name is Jacqueline Boehm. I'm a rising fourth-year student at Harvard Medical School. And technology has been brought up various times. It's something that's extremely exciting to me. I firmly believe that we're in this exponential technologic phase of the growth and development of the human species. So thinking about examples and potential applications of this, there's a surgeon, Dr. Jacques Morescu, who performed the first transcontinental cholecystectomy. He was in France, and the patient was in New York. We use telecommunication video mobile devices for interpretation at hospitals, at Cambridge Hospital, Mass General, various hospitals here. And I'm just wondering if we could take these same technologies and try to leverage them to meet the global needs that we have in surgery, critical care, and some of these things throughout the world. Thinking, are there applications for a surgeon here in Boston, for example, to train someone in a resource-poor setting across the world with some of these technologies? Can we have a surgeon somewhere in the United States or a high-income country round with teams on a critical care service in a resource-poor setting? And then thinking about those applications, should we be looking to partner with some of the multi-billion-dollar innovators on the West Coast over in Silicon Valley to help create more permanent and health systems sustaining infrastructure for some of these countries? Thank you.
How did I go from 14 minutes to flashing red in 2 seconds? What happened there? Speaking of technology, what's going on?
I didn't think you'd notice that.
Yeah.
No, how about 10 more minutes?
Sure, okay. Oh, good, it's counting up now. This is great, good. It's getting less red. Who wants to tackle that question?
One of the things I would say about that we really need a long-term commitment. So short-term training opportunities or just rounding a facility isn't enough comprehensive exposure to the type of training that's needed on the ground. So in my experience, if someone can give a 3-month commitment, a 6-month commitment, like real time on the ground to build capacity, that's a very different story than having just an exposure to the work. And preferably, if you can't do that stint, to at least come back like every 6 months or once a year to reinforce the type of training that you had offered them here in the US, or even if you go and visit and train. It's really that you need to have a comprehensive, like, building capacity presence on the ground.
It's one of the things I would add to that is, as we're looking to build a framework for safe surgery, localization is something that we really strive in order to achieve sustainability. But at the same time, we have leveraged technology, especially in the US setting, and something that we're looking to take to some of these developing country settings is telementoring, which is taking specialists and teaching primary care physicians or in very rural setting to be able to, as you can imagine, sort of Hollywood squares or virtual grand rounds where you're really teaching them and building the skills of primary care physicians. And could that then potentially be translated into surgery as well? So there are some innovations that we're definitely looking to see if that's feasible in some of these countries. But at the same time, you also want to make sure that any intervention that you do is sustainable and can work in a local setting.
Raymond Price, Associate Director of the Center for Global Surgery at the University of Utah. Working with the Society of American Gastrointestinal and Endoscopic Surgeons in laparoscopic development around the world, we've continued to run into the issue of needing equipment, but also into conflict of interests of working with various companies. And can you help us understand how we can solve the problem of the conflict of interest between trying to develop a business versus an educational product out there, and how we can bring those together? Because I think there has to be a solution that we can bring industry together. On SAGES, as we've worked on this, we've had to try to keep them off the committees and keep them off the different areas, whereas some sort of partnership to bring in together, I think, is really needed to solve this critical issue in getting surgery into the developing countries.
I'm shocked that you would even run into that kind of problem.
Yeah.
And I'm
the
not
premise
sure
of the question really surprises me. I wouldn't think that you'd be worried about companies getting too rich by donating equipment to the low-resource world. Really, maybe I didn't understand your question.
I think the problem isn't so much about the countries getting rich.
The companies, I mean.
You've got companies as well as universities. You have all sorts of different people. And all of a sudden, the question is, well, we don't want the company to tell SAGES what they have to do either. They're bringing in the money.
Right.
And there's been real conflict of trying to work with industry. How do you get industry with this conflict of interest to work together?
Right. So the training that we've done, we haven't been directly involved in the final venue for training. So as an example, we did a 2-year project in Sierra Leone at Connaught Hospital with Johns Hopkins University, the austere anesthesia group there. And we maintained full arm's length away from the training. We did provide equipment and we did provide funding for the training. The training went well beyond the use of general anesthesia. It was a full-on anesthesia course for anesthesia clinical officers there. From my perspective, we got value out of it because actually we learned from that training course how people interacted with our machine, and it gave us some input about how to change the user interface on our machine. So I got value from it even by not being there or not being part of it. I suspect that if there is industry involvement and industry is looking at education as a marketing tool, then there will be conflict. From my perspective, training is actually a more infrastructural development of the marketplace. And if it benefits me, that's great. If it benefits anesthesia machines from some other company, fine, because ultimately the goal is to increase capacity in the operating room. So perhaps it's a matter of optics, and from industry's point of view, a commitment to investing in the general market, not investing in a specific customer, trying to recognize a gain from education. I can't really imagine education as being positioned as a commercial transaction. I think that has all sorts of problems.
Yeah. I would just add to that as an example of living proof of I guess, with this conflict of interest, having a medical device company. From our standpoint, we've shifted from equipment donation as a foundation to really capacity building and clinical training. And that's really the focus that we go in with, whether that's equipped, and equipment then really becomes a complementary factor to it. So for example, the nurse anesthesia program that we have in Kenya with Kijabe, it's really all about that capacity building and the training, but if we are able to equip the facilities with our anesthesia machine, then that's great. But BMET's another example of we're brand agnostic. Our goal is really to be able to enable the technicians there to be fix any equipment, whether that's us or in any of our competitors. But the idea is really to be able to build that skills. And just one last point is that in the private sector engagement, it goes beyond the funds and the equipment. It's really what other expertise can we bring to the table, and that's where I think the private sector could play a significant role in safe surgery, whether that's in the form of leadership or processes or expertise that we could bring in from the manufacturing background that we were able to enable in the safe surgery space.
So I think we're almost out of time. One last question. Dr. Tarpley, one last question. It's always time for
I'm just continuing on my mistake stream here. A couple of quick things. We used to say that the developing world, the third world, now we say LMIC world, is littered with broken equipment. And I would tell you that as a surgeon at a Bomashaw, the guy that could fix something was more valuable than the surgeon because there was somebody else that could do the hernia and could do the C-section and everything. And this is really an underrepresented, real need globally, at least in my experience in sub-Saharan Africa. My confessional statement is that I misspoke earlier and that GE is the one that's actually funding the work with Newton and the people from Kijabe in Western Kenya. And Ms. Varghese was very forgiving and nice to me, but I wanted to make sure everybody knew it was GE. Thank you.
Any summary comments from the panel?
Yeah, it was interesting to talk about the conflict of interest. The conflict of interest that we see much more commonly in industry is just the business model. And again, I think that this is a demand-based issue. So in a context where you're providing equipment for free or heavily subsidized, typically the unknown cost is the cost of ownership. So consumables, whether it's disposable sensors, whether it's a long-term maintenance contract, whether it's the software contract. Typically, those contracts are of a limited duration, and after that point, the hospital needs to continue to pay to support this equipment. It's sort of like a free Ferrari giveaway, which is like amazing for the first couple weeks, and then you find out how much gas and new tires cost, and oh, sad, I got to put the free Ferrari in the garage. So I think that this free Ferrari mentality, so how do we really account for the total cost of ownership and incentivize through better RFPs and service contracts sort of the best behavior?
I think similarly, one of the issues that we find is the people who buy equipment are not the people who use equipment, and there is incredible disintermediation between the two. So we do get RFPs from ministries of health or NGOs without any input from the clinical providers in the field who are actually going to be using this equipment. And that leads to specifications for unicorn devices that don't exist, or devices that simply will not function in the environment that they're heading for. So one thing that I think we should strive for is greater involvement by the clinical providers on site in these operating rooms into what kinds of equipment they are being provided with, and their voice needs to be heard in that decision.
So I'm about to jump into a mini speech because this is so important to me. Those of you in this community that really know me know that I'm somewhat obsessed with biomedical equipment management. There's a reason why I have that obsession, and I've really come to it honestly because I've had major successes and failures, and I've learned the hard way by doing it. If I convince you of nothing else, it's that your aspirational clinical goals will never be met without total commitment to biomedical training. If you are building surgical services and medical universities in resource-limited settings without equal commitment to biomedical training, your efforts will fail. I know many of you in the global health world, I know you care about the work, but somehow biomed always falls to the bottom of program design. I want you to understand it needs to be at the top of program design. I've worked with countless clinicians that bemoan the lack of working equipment, but I've never met any that are willing to commit the necessary resources to equipment management. This isn't an extra, this isn't a, wouldn't it be nice, this is it. If you want successful surgical outcomes, you have to have reliable working equipment. There's a lot that goes into that equation. You have to do your due diligence on the equipment. You have to have enforceable warranties and service contracts. Donated equipment can easily cost more than buying equipment if you don't understand the life cycle costs. You have to have preventative maintenance plans. You have to have plans for procuring spare parts. Ideally, you'll have regional service support, but most of all, you have to commit to training techs on the ground, training and retraining. Biomedical techs are heroes. They are overworked and underappreciated. We have to invest in them. It's the only way we'll get it done.
On that note, I think I've shifted a little bit from focusing on equipment to really focusing on capacity building and health system strengthening. So as you know, as we've planted a lot of programs, whether that's biomedical technician, nurse anesthesia, oxygen delivery, all of that contributes to safe surgery, there's a lot more that needs to be done in this space, and it's going to require a great collaboration. So I think someone eloquently said before, silos create competition in human resources and staff, and collaboration really strengthens system. So that's what we're hoping to do in this space of safe surgery and being able to build that framework. And we strongly believe that 2015 is the year for global safe surgery to be in the space of global health. So thank you.
Well, I'd like to thank my fellow panelists and the organizers for giving me a chance to be part of this great day.
Nice job. Nice job.
Thank you, George, and I'd like to thank the panel as well. We ran a tiny bit over this morning.